Hello, following is an interview with Dr. Chris Moy, previous Vice President for the Australian Medical Association, and myself. In this interview, we cover things like primary community care, evolving practice and how that's going to change in the future, bulk billing, disability, advanced care directives, the NDIS and the health system, and whether or not we have a hospital-based system or a healthcare system. Enjoy. So, Chris, for a couple of years there, you were Vice President of the AMA, and prior to that, it was for South Australia only, is that right? And what possessed you to go and do that?
I'm very much the accidental leader. I never saw any of these. It was only because I'd been involved in some major projects behind the scenes, development of the My Health Record and digital health in Australia, which became really useful during the COVID pandemic. Cool, yeah. And also the development of things like the advanced care directive in South Australia, and also end-of-life policy, the 7-step pathway, and those sort of things about trying to improve end of life for the many people that I see working in aged care. And it was because of those things that I got roped into the AMA, and somehow at the end of it I ended up doing the South Australian presidency and then later the vice presidency in Australia.
So an advanced care directive, if done properly, can be very much like a living will in a way, in that it can be like a very binding care plan to give people control in those final stages. Is that something that for disability could be adapted so that it's not sort of just in the final 6-12 months that...
I think people actually misunderstand what an advanced care directive is, because in fact they actually focus only on end of life.
Yeah.
An advanced care directive in South Australia is a legal document which actually represents you when you can no longer speak. So in situations, so you complete it when you can actually indicate your wishes clearly. But then at another time when you lose decision-making capacity, it's you, it represents you. And so it's applied not only at end of life, it should apply for things like major personal and residential decisions and things like that. But more importantly...
So you can put those things in there. You can put in that, grandma's a vegan, if you're helping somebody. Their religion is they are a Hare Krishna. These are the people that she doesn't want to see.
But it should also be about you, about what's important to you.
Yeah, well, if you have to help somebody, you can help them in that regard. But if you are writing it for yourself, there is that scope for somebody who would never want to go into a particular nursing home, or I had somebody who didn't want to go to a particular hospital. And when he was taken from the nursing home, we had to have a much longer drive, because one thing that paramedics are very well trained in is advanced care directives. And I've never had an issue with a paramedic. They know exactly what they are, they say it right, and they just make it so.
It's interesting because even then though, you've actually mentioned only the negative things, when not to do things. And look, so a lot of the advanced care directives are about, for example, I don't want resuscitation, I don't want to go into intensive care unit, I don't want to go into a nursing home, those sort of things. I don't want you to talk to my sister-in-law who I hate about anything. They're all fine, but it's just important to write positive things about what's important to you. I'll give you an example. I mean, there have been situations, and we'll take it back to end of life, but we've had situations where people have written my family's the most important thing for me. I love my family.
Oh, I would like my dog there.
Yeah, and so it's an interesting thing because, say in advanced care, say somebody's decided they don't want any more transfusions, for example, but they're dying from cancer, but they're happy to pass away slowly, and that's their wish. Somebody writing that my family is really important to you can sometimes be useful in overriding that. And we've had situations where somebody has come up to me and basically said, look, can you please give this person one more transfusion? And I've said, well, actually they didn't want any more. Why are we doing another one? And he said, because family's really important, and their son's flying over from overseas for the last time to see them.
Yeah.
So writing something positive is just as important, and what important your values are.
I have seen that with somebody who had a son coming from another state, and the woman was very elderly, and so they did intervene, which gave her more time to do that. I have seen that occur. It's kind of like, and you probably won't like this, but a bit like a death plan as much as like a birth plan is.
Well, I'd even...
Or like your own little personal end-of-life doula, where you get all your stuff in order for yourself and with your family.
I think for a lot of it is the focus, but I think for me, what I want to see is the humanity in it. Because understanding the human being that is writing the advanced care directive, like my family is really important for me, I love my dog, I love Mozart, these are, my values is I don't want to be a vegetable, dignity is most important. All these things are just as important because they actually tell me about the person and actually help a doctor and their family when they're making decisions, when you've lost decision-making capacity, make that decision. So it's important, yes, to write things that you don't want to happen to you, but it's also important to write things that are important to you. And I've got to say, reading the humanity in some of them as a doctor actually helps just as much as knowing what people don't want done to them. And I think, so getting that balance right is important. It is basically you when you can no longer speak. And so that's why they're really incredibly important documents. So they're not just end of life, they're you. They represent you when you can no longer speak, either by writing down your wishes or actually nominating a substitution maker who is therefore your legal representative. And their job is to do what they think you would have done in the circumstances.
There's generally somebody that would know you very well, and you've had that conversation with them at some point. One of the things that changed, and I had some input on this with the Advanced Care Directive, was explaining about those things, about what resuscitation was. And I don't think that I understood it, because everybody thinks, oh, it's just CPR, it's just the chest pumps. Whereas it's so many other things. It's whether you want a feeding tube, whether you're going to have saline, or you're talking about transfusions or all kinds of interventions. And they've sort of laid that out a little bit more so that people understand, do you want to be resuscitated? When people ask that in the hospital, what resuscitated actually means. Because somebody might say no, but I do want antibiotics, or I do want...
Absolutely.
Yeah.
What I would say though is it's very difficult for people to write, because you should be writing Advanced Care Directive when you're young, because you never know when you're going to fall off your bike and hit your head. You should be writing that when you're young. There's a chance at any time you could lose decision-making capacity. So the thing is actually, from my perspective, over time, I used to think it was all about no resuscitation.
Yeah.
But in fact, now my belief is it's just as important to write down what's important to you. Like, for example, your dignity is most important. You don't want to have brain damage, live with brain damage forever or whatever. Because there is a separate document in South Australia called the 7-step pathway, which is actually what the doctors should do to transfer that into clear medical instructions. So what should normally happen is, say you as a individual have an Advanced Care Directive, write down all the things that you don't want, but also things that matter to you as a human, as a
I've
human
thought
being.
of everything, and it's all there.
But there's no way you can cover off every medical contingency. No. What doctors can do then is fill out a form for you called the Resuscitation Plan 7-Step Pathway in South Australia, which can be used in hospitals and in aged care facilities and disability facilities. But the critical thing about that is what they can do then is convert your wishes into clear medical instructions. So if an emergency happens later, say you do deteriorate. Say you've got a real terminal illness and you've decided you don't want any more resuscitation, no more ICU, whatever. That you may write there, I don't want resuscitation, I don't want intensive care unit, but I'll be willing to try a course of antibiotics, right? And if that doesn't work, then I want palliative measures to make sure I die peacefully. So what it does is you've got the Advanced Care Directive, which is the person's document, which actually conveys things, as I said, that you specifically don't want, but also things that are important to you.
And that's the parent document. It has to relate to that.
That is the legal document.
That's the legal document.
But there's this Resuscitation Plan 7-Step Pathway, which is kind of like a clinical plan for doctors to be able to complete, so that in an emergency at another time, another place, middle of the night, when the nurses are coming to you,
they know how to fit that within your wishes.
They know what to do.
I've had that misunderstood in the past in hospitals where they've had an Advanced Care Directive for a client, and then they've come in, but we've got our 7 steps. And it's like, well, they can fit in with that, but that is...
They should be aligning.
Then it's like, well, you must change this person's Advanced Care Directive. It's like, well, obviously I can't do that as much as I could do yours or anybody else's. So there was that misunderstanding there of, no, the legal document is the Advanced Care Directive. And it's been tried. I mean, the story of a lady who was resuscitated, who didn't want to be, was extremely annoyed, and, you know, it was proven in court. It's a lot harder to do it if it's the other way, but because they can't take you to court. But it is something for people to understand and to be aware of what their rights are, and so that they can be prepared. One of the things an Advanced Care Directive doesn't seem to cover is if you're under 18, so maybe parents of a child that's ill, so that the parents can be on the same page together. I felt like there was scope for that in the future. For help with that.
Part of the problem is then it gets into the blurry stages of decision-making capacity at the younger age group. So, look, at the moment we're having enough trouble getting enough people to do the Advanced Care Directive, so let's work on that. There may come another time and place where that will come into be.
But certainly for people with a disability who are not palliative, which some people don't understand with some of the more pronounced disabilities, that actually they're not palliative. That's just how they are. And when they present in hospital, they don't look well. They're generally not having their best day, but want some sort of a plan if something should suddenly happen. So it is still something to do, even though, you know, you're not, you know, planning on going anywhere in the next 6 months or 12 months, but it's nice to have it there so that it's, and then your team also know.
And that's important.
So if you can't speak, even if you can, but for that moment you can't, they can ask your, you know, team member or whoever you've allocated to what am I directed to do here.
One thing about the Advanced Care Directive, if you complete one, the first thing is that you need to let people know that it exists.
Yeah, that works.
You need to know, you need to keep copies, certified copies around the place so people have them. Ideally upload one to the My Health record so it's available. But
it's actually quite easy to do. I have done that.
One of the other things is that with your substitute decision makers, it's really important you explain to them what their role is to do what you would have done if you were able to. But I think the other thing just to really keep in mind about substitute decision makers is you don't always pick the substitution maker that just loves you the most, because you have to pick the one that is able to make the hard decisions that you would have made. Because unfortunately sometimes the one you love the most
won't do it.
Will actually make decisions because they love you that won't be in line with what you would want. And that doesn't mean you don't love them back, but you have to be careful about making sure that your substitution maker is able to, and what I call act in your shoes. They could actually fit in your shoes and think it out and make the decisions that you would have made in a certain circumstance.
So they're easily downloadable online and you can just print them out. I generally have them in people's care plans. You can print them and it's not very difficult. And it sort of promotes some discussions that many people in that situation aren't particularly happy about having. One of the things I've noticed in the role of support work is the lack of communication between the NDIS and in this state with SA Health. I'm aware that is often the case in other states as well, though I believe Victoria and possibly New South Wales, I'm not sure, have a disability liaison in the hospitals. Are you aware of other states having that, and has it helped at all?
Look, I think part of the problem has been the genesis of NDIS. That's just the way it came about.
Yeah.
I mean, it was
it was kind of like Jack's Beans, wasn't it? It's just suddenly...
Well, and part of the silo approach to the whole of health and disability. So what you have a very difficult situation where you've got state governments basically running hospitals.
Yeah.
You've got this Commonwealth bureaucracy which has been developed extremely quickly. It's come out of nowhere and it's massive now, but it's still finding its feet. And you know, we've discussed previously how it really didn't even realise it needed sort of standards and safety and quality and all that sort of stuff. I mean, all these things have just arisen really quickly, developing a system which is a massive thing now, but ultimately having to deal with its own issues and really ending up in the same situation that we have with aged care as well, where it's in another silo which doesn't interact with the state health system very well.
No, aged care and disability don't talk to each other either.
They're shocking.
So we've got lots of little silos. So it is difficult.
Funding matters, because the problem is, and this sounds terrible.
It's funding that causes the silos, do you think?
So, absolutely. Funding silos, but also the administration and governance, but none of them owe each other anything. So let's be frank with you. Aged care is where I've worked a long time, and part of the problem has been, you think about it from a poor nurse in a nursing home who is having to work with a patient who is deteriorating, right? Now, they might be able to manage the patient there, but they're worried about their medical legal risk. What's the easiest thing for them to do? Flip it onto the state health system, which is a different funding model. Now, the problem is that there's this, each system is almost like they don't work together. There's very, very little conversation between each of the silos. So really, if you've got a problem and you're worried about the consequences, it's much easier just to flip it onto the next silo, which is the state health system, which sounds terrible, but the same thing is going to happen in disability. And the problem then is that they don't owe each other anymore. There's no chips in the game. There's no incentive for that.
There's incentive to handball.
There's no incentive to try and do your best to keep somebody there and take a risk, or to actually do the best you can for the patient. There's incentive definitely to move on to the next silo and remove the risk.
Palliative is probably not a good example, because we've only got 1 in 6 hospitals in the country that have palliative care facilities, isn't that right?
Oh yeah, but palliative care is...
It just sort of happens where it happens.
And honestly, it's not... Look, the majority of people don't necessarily die under an official palliative care service, because majority of people...
Well, 80% of people apparently want to pass away at home. And I think that would be a lovely thing to get to. I think we need a lot more planning and education around that to get there. But I think it would be... I myself had a home birth when I was in London. I had a company called Caroline Flint Midwifery. They were absolutely top-notch. I totally trusted her, and it wasn't that I had any adversity to going anywhere or anything. That's what I just decided I wanted to do. And no, it didn't quite go to plan, but I did do it at home, and I didn't have any pain intervention, and it was probably my best birth, and I was very lucky. But for a lot of women, that doesn't happen. But palliative care, I think you could definitely have that with family feeling that they can't cope, because there's that whole support work network that needs to, because it's a protracted period as well. No one can say, with a baby it's going to come in the next couple of days, worst case scenario, or we're going somewhere anyway. But in that situation, people must have died at home at some point.
I think
it would certainly help to free up beds.
I think there's been a lot of work from Palliative Care Australia. We've done a study, quite a big study, that showed the benefit of actually properly funding palliative care so people can die at home.
Very progressive study, yes.
And there's a lot of cost benefit for governments. But again, this is part of that silo thing. Governments are very, very caught up in the whole, unit cost for a hospital bed, but they can't think outside of the square to fund the services out in the community. And there's just a lack of that sort of forward thinking, and it has been for a long time.
Well, everyone has their own assumptions, but nobody's sort of done a training program to teach everybody that. So you turn up at hospital with a client who has a profound disability, and the doctor may or may not know what's going on. Quite often you may know a little bit more, just sort of get them started. You'll know the very basics. Well, you'd hope so. And then you've got a medication list, you've got a care plan for somebody who's at that high intensity level. And then they just sort of go, thanks. And then, right, off all your meds, and we're going to do, and you say, well, I've got this specialist here and I've got this GP here. We don't do that here. It's like, well, one's a mister, one's a professor, and I do as I'm told, and you kind of it would be really cool if you did, because quite often as a coordinator of support, I feel like I report to, not only to the client, but I keep all the medical people informed, make sure everybody's got everything. So if somebody gets a discharge, we'll share it, you were lucky, bingo. And then we share that out and we keep the communication going. the team going, because if we come to you as a GP, we've got 15 minutes, or as you were saying, if you need to book an extended appointment, if you need, you can't stretch it. And it's very difficult because they quite often think that as support workers that we work for the hospital, or we're bank staff, or we're casual. I've even been bullied as that, get off your ass. It's like, you don't mind. So they don't know, and it's not their fault they don't know. So there's a lot of genuine misunderstanding. And if you can't attend to your client in hospital because it's so casualised, they lose their team. And then you can't send them home because they haven't got anybody, because the shortage of staff at the moment, you can't manifest something that doesn't exist.
No.
No. And with the ageing population, we're not even at our peak. No,
not even close.
So when do we get to our peak?
Oh, look, the statistics are extremely scary. I haven't got them in front of me, but we're still very much on the upswing in terms of the ageing of the population and the huge needs that are going to be required for the ageing population, which is very, very scary for a whole number of reasons in terms of aged care, but also healthcare provision, because we're talking about a huge sort of spike in management of chronic disease for people that are going to be, have difficult issues with mobility and things like that.
Well, we don't even have housing that provides for that. So you might have somebody that maybe has the money to pay for their own care privately, but can't do so because you don't have access in the home, and they don't know that when they've bought the home, or that they can't prepare for that. And it might be like 100,000 or 200,000 to start knocking down walls so Nana can, go to the toilet. So those people have to go into a nursing home, whereas perhaps they could have been looked after at home. There don't seem to be any financial instruments either in aged care for people to be able to prepare for care. There doesn't seem to be anything in private healthcare to cover that. The assumption is that the government will, with no sort of option to maybe financially prepare for your private care. I mean, private care, you're looking at maybe $8,000 a week, something like that. So, depending, whether it's 1 or 2 years of the end of your life, that's a fair amount of money. Do you think that's something that fund managers will look at maybe in the future? Have you heard anything?
Not really. I mean, I think people have been even trying to work out issues about things like super, and I think Paul Keating just mentioned recently, I think, about some sort of aged care fund that you save up to be able to help. Those sort of things are definitely in the works, but we haven't even got super right at the moment, and the magnitude of funding for the super isn't even close to what it needs to be, so we can't even get to that.
Well, I was reading this morning that we're going to need something, like over 600,000 social houses by 2032, and the Labor government have put quite a big amount of money in, and that'll knock off about 3% of that. So I think we sold off a lot of social housing, and then we didn't sort of build any more. And now we've got this massive rental crisis and housing crisis. And so with that in mind, the belief is that the specialist disability accommodation is going to accommodate for that. Whereas in reality, that'll be about 33,000 houses across the entire country over, a decade or so. They're not going to just manifest themselves. It's only for 6% of the 10% that are actually on the NDIS. It's not meant as so Housing Trust used to provide a great deal of housing for disability, but I think it's about 16% now. So that's certainly something that I'm interested in. Do you feel that better communication is the answer with the NDIS and healthcare, or do you think there needs to be a memorandum of understanding? Or, where would you start with something like that?
Yeah, unfortunately, NDIS didn't get off to a very good start with health, unfortunately.
Well, because they're so anti-health, Chris.
Well, that's actually part of the problem.
Yeah, because it's Section 34, it's reasonable or necessary, you don't do anything with health. And it's like, well, actually, these people can't spend, under the COAG, you're allowed to attend as a support worker if the person has communication difficulties or psychosocial, which is 80% of people on the NDIS.
Part of the problem is that you've got to remember if you look at it from a general practitioner's point of view, so the focus was, the assessments were all on care level, but nothing to do with medical conditions. And it was trying to be demedicalised, which I understand. But the problem was that for a lot of GPs, the first assessment requirement was patients coming in and saying, you need to provide me to complete this NDIS form with all the medical conditions. When early on, it was actually difficult to work out whether a GP would actually even be able to charge under Medicare for this sort of service. There was actually concern about that. There had to be clarifications.
Well, that's true, because many other specialists will be paid either privately, or that's why they're trying to get the OTs to do it all.
So these were quite extensive forms, as you recall.
Yes.
And so first up, there'd be no consultation on the complexity of the forms. There'd be no discussion about whether we could actually, charge the government to be able to complete these forms, and then to be told that really, doctors had no part in this at the same time. So it didn't get off to a good start, partly because of the genesis. Now, I think there's been a big realisation that, doctors do have to be a part of this, for many conditions, because you're treating conditions quite often. And so I think that there has been a move the other way, but we're still a fair way off. That's in my world. In the hospital world, I think that there's been, really a very, very difficult relationship between NDIS and hospitals, mainly because, unfortunately, because of the two difficulties. First up, the difficulty, not enough hospital beds, not enough doctors, not enough nurses, not enough time, and particularly under COVID, the feeling like there's been, unfortunately, lack of effort by NDIS to really support some patients who didn't need to be there to be able to transition out of hospital, and therefore meaning that they were under more pressure. But also just the fact that doctors and nurses were under such enormous pressure looking after the load that was coming in, and therefore having this extra load there, which there was a perception, which I think sometimes was unfair, that there was an extra load that they were being given that was set up because of bureaucratic failure on the part of NDIS, has actually meant...
I think that's probably true.
Yeah, but there's been a sense
because if you need to get onto the NDIS, it's like with the doctors, has to manifest this magical report. You suddenly need someone to do all those paperwork and coordinate it with you. Now, that might be 10 hours, it might be 20, it might be 30. Now, if you don't have the plan to do that and the plan to spend the $3,000 on an OT report, well, so the burden has come upon advocates in a big way, and it doesn't just manifest itself. There was nothing to assist people getting on, or no sort of parameters for what they actually needed. So people were, in some cases, overspending and getting one of everything, and in some cases they'd have entirely the inappropriate thing. So a lot of people that become support coordinators just have done sort of like a half-day course, and they were support workers, and they may not know anything too much about. They've had a very steep learning curve, and a lot of them are doing really well, but there is a level of incompetence, and then there's certainly a level of competence with the LACs as well that they didn't necessarily understand. So you have participant, and they might have a support coordinator, or they might not, and they might have an advocate, and they might have a nominee, or they might be speaking for themselves. Then they might have the support coordinator, but then they might have also an LAC, and then after the LAC they might also have with the NDIS. And if they're complex care, they'll have a senior planner, so there's no LAC, it goes straight to there. And then when you think you've got it, they make another announcement and it's all changed again. It is very...
And look, can I just say that it's interesting when you talk about all that, because my point, and it was interesting, you asked me to have just talk about sometimes the difficult relationship between the health system and both individual patients on the NDIS and also the carers. I think one of the big things is to understand that, and I've always wanted to say this, doctors and nurses are just people.
Yeah.
They're just human beings. And that one of the big problems, both in general practice but also in hospitals, has really been the fact that due to a lack of resources, lack of beds, a lack of time, a lack of funding, for example, for Medicare, really what's actually happened is time is shortened. And so the amount of time that I've got to say, this is the sense that I have when I'm doing medicine quite often. It's this time is going on all the time because you realise you've got to get to the next marker. You've got to, the appointment time's finished, or you've got 10 patients waiting out there. You've got 10 other patients you need to see, so that poor registrar knows he's got to assess 10 more patients for the day. And so what I would say is, sometimes we do get, you have that sense sometimes that there's a slight, antagonism between the two systems, and sometimes you may almost feel, you see stress in their eyes and resentment sometimes because they feel
that resentment may not be for you. It's resentment for what they're going through. Yeah. And that has come to light of late with doctors wearing special T-shirts,
They're human too. So what I would say to you is, you ask for advice about what people can do.
Definitely.
Look, for a general practitioner, I would say try and find a good general practitioner that you can relate to. Continue the relationship. Yeah. Don't keep on chopping and changing. It's really hard for your a new doctor to pick up where the next one went off, especially with a complex history. Make sure you book enough time for them. Don't just book a 15-minute appointment when you've got 20 things to go through and feel upset that you can't get through them because it's not physically possible, in the time. And, just understand they're human beings and just understand some days you're going to have worse days than others, and because they're just under a fair bit of pressure. Now, in hospitals, look, that's a more difficult thing because you often haven't had that relationship there. Understand what they're going through, and that's probably the big thing. That doesn't mean that you should accept, rude behaviour. That's not what I'm saying. But, I've got to say, what I've seen occasionally is the box of chocolates and a bit of sympathy about how stressed they are actually goes a long way to actually getting you to understand, and also making sure that you have all the information that you can in order, particularly a medical summary, either a medical summary which you've got, or what I think is really useful is to have that medical summary on the My Health record, which you can have it printed out in paper form, but also you can also, very soon you'll find there's all these apps which can actually show your medical summary on a phone, for example. And what it means is that doctor spends less time going over the main issues, main medical conditions.
And it's in a familiar layout as well.
And it can start processing how to put it into context of why you might be there.
Yeah.
So the less time you have to spend going through the calculation, because in medicine, although there's a human aspect to it and obviously the connection, and that's what people really like, a lot of it is still a problem-solving exercise. When somebody comes in to see me, they've come in quite often with a particular problem, and I'm trying to do the calculations about, okay, this is their past history, this is their family history, these are the medications they're on, these are the symptoms they've got, this is what they're worried about. I'm trying to work out what could be the cause and what could be the problem.
And they may not be telling you the information you need to know. It may be something that you are observing.
So if you're unfamiliar with somebody, particularly when you go to hospital for the first time, having that information straight in front of you, the key information, the medical summary, the medications, the allergies, and advanced care directive, by the way, is really helpful because straight away you've picked up the information much more quickly instead of having to re-go through them one by one, and then going through the process. So I'm just trying to give you tips
so
about things.
Providers made their own sort of care passport type thing when somebody goes in. That's as much information as possible, and appoint, the GP, please send it back to them, and then make sure you follow up with the GP when you've come back out to check the medications haven't changed and if there's any alteration to the care plan, and build the relationship. So what does it mean with this bulk billing thing for people?
Okay, so bulk billing is where the charge, so there's two ways of billing. Okay, we'll start from the start. When Medicare started in 1984, what happened was the Medicare rebate was never meant to be the full payment for a consultation. It was meant to assist people to pay for the consultation, and it was supposed to be 85% of what you call a total fee, and the 15% is the co-payment that you would pay. Okay. There was the ability to do this thing called bulk billing, where essentially instead of this co-payment, the GP on your behalf would charge just the 85%, right? Would take a 15% cut, And then what would happen then is, and that was primarily for people who were did not have the means to pay for it, and that would include people who were on a
DSP,
pension or something like that. Yep.
Or maybe it was just to write a script, or
What has happened over time is their Medicare rebate, the amount that the government pay for a consultation, has really dropped off over time.
Yeah.
And so essentially it's only about half or less than half of what it should be. So the average rebate for a 15-minute consultation is about $38, which, let's think about this, is about the same as a haircut at the moment, okay, or less than a haircut possibly. But the thing is that should be around about, if government had actually increased it by CPI and did not have the freeze, it should be closer to $90.
Okay.
The problem is that that becomes so. What has happened over time is that more and more people have been bulk billed over time, but that bulk billing viability at $38 is almost impossible, because the general practitioners, people think general practitioner when you see them,
you're not going to fit 4 in every hour.
But not only that, you don't get paid anything like that. Essentially, most of them, at least half of it's got to go to the rent, to the staff, to the insurance, the looking after the nursing staff that care for you afterwards, those sort of things. So over time, it's really dropped off to where it's not viable for a lot of practices. So practices have to make 2 choices. They either do a thing called volume, where they see a lot of people really quickly, but you may have seen those, being in practices like that, where it's felt like...
Yeah, it felt like you're permanently at the orthodontist. Remember, they sort of went in one room and the other.
For viability, that's how some practices have gone. The other option is people charge a gap. But the gap, if you want to do a gap, then you're going to charge $100 because... Yes,
I have had some GPs, because we moved recently, who said that, it's $150 to go and we don't bulk bill.
And that's part of the viability issue, because what they're doing is they're paying for their rent and the insurance and whatever. So it's one of those tricky balances that practices have had to make. And the problem at the moment is that the way general practice has funded this sort of fee-for-service thing where you pay this is something that has to be looked at, because it's just not fitting what people need all the time.
And is that why, when you're trying to make an appointment with a doctor, it can take so long to get an appointment, because they're seeing so many? They have to see so many?
No, actually, the biggest problem at the moment is nobody wants to do general practice. It's really scary. Because of the lack of funding of general practice, for exactly the reasons I've said.
Because you have to do all sorts of things, from work cover to disability assessments to
with the rebate so
GP
low,
care plans.
With the rebate so low, general practice incomes, being frank, are nothing where they should be. So it's become, there's been a lack of viability, and what's happened is unfortunately, just to give you a very scary figure, Mark Butler, I was in a meeting with Mark Butler today, and he said the figure that terrifies him the most is the most recent medical training survey showed that graduates, there's only 15% of graduates want to become general practitioners. 15%.
I did notice when the RA first opened that we seemed to have a lot of sort of expat type doctors, which was nice. It seemed to be like a League of Nations in there, and you think, oh, that's great, they're going to bring all their experience and knowledge, and and then they seem to disappear. Well, did they go home? Yeah, so thought, oh, we're not doing this.
The problem with general practice is we really need about 50% of doctors, graduates, medical school graduates. 50%.
Not 15.
Not 15. And so at the moment, this is why when you want to see a doctor, it's very hard to see a doctor at the moment.
Well, they have to be like octopus.
Well, because over time, for the first time in the last few years, it's been hard to fill the training places for general practitioners, which is a really scary prospect, which is why there has to be some work in trying to bolster the general practice training area. And it does mean great investment by the government in this area, because what they've allowed it to do with all the freezes and the not matching CPI is let it fall so far behind other areas of medicine that it's almost not viable for a lot of general practices at the moment, unless they then privately bill, and then we're talking about these very large
There
gaps.
are some people that just couldn't do that, so they're going to turn up.
And that's a false economy for the government, because obviously when you turn up at a hospital, I think we're talking several $100.
Well, the doctors don't tend to be largely available after 9 to 5 on a Monday to Friday. Is that because the bulk billing doesn't cater for that?
Well, so first up, if it's not viable during the day, it's going to be even less viable after hours.
Yeah.
And, general practices haven't had the luxury of things like, double time and a half or anything like that.
So the bulk billing doesn't cater for that?
there is a slightly increased fee for some after hours.
So if they did, though, that would enable people to attend outside of work hours, and that would go a long way to assisting emergency departments.
So yeah, bottom line, if it's hard to get enough people to become general practitioners during the day, it's going to be even harder to get them to work at night, especially.
No, maybe if you get them in a sentence, flexi time.
And don't get me wrong. I mean, the thing is that look, I've just finished my roles in as leadership type roles, which have been really interesting, very, very stressful at various stages. But can I just say to you that, like, the doctors I see really care, and they're really trying really hard. And I must say, having finished now, I actually appreciate the clinical work even more than I did before. Like
You missed it.
Yeah, I missed it a lot, actually. I realised how much I missed it and how much I care about caring for people. But there is this tricky thing where the viability side of things, if you basically can't, in a situation where you can't fund the practice, essentially, then it becomes a really tricky line, because...
Well, it becomes things not just about, how much you're prepared to take home, but not being able to provide adequate service.
Well, and not only to be able to pay the staff and to have enough good nursing staff, good administration staff, provide the right equipment. Just to give you an example, sometimes, the dressings that people come in for a dressing and when you've used all the dressings, they can cost more than the consultation.
Yes, I know dressings cost money.
It's like there are times where...
I know. I have to keep a kit in my car. I have a defib in my car, and I have a fairly extensive kit. And when I have to replenish it, it's like, and it doesn't. They don't go down in value either. It seems to get more and more expensive.
But look, it wouldn't be great work. I mean, look, as I said, I've gone back to clinical work and enjoyed it even more.
You're enjoying it,
and really being able to focus on it again. And in fact, I think probably having been working in the rather hard and cynical world of politics and media, I feel even more love for the clinical work.
But I do have a great deal of respect for politicians, because it's got to be damn hard, hasn't it?
Oh, yeah.
Because, I don't think that I could do it, so I try not to be too critical of it.
I think the only thing about politicians I find is that, look, I think the thing is I do agree. I'd hate to be a politician, because I think ultimately they start off with the idea of service.
Yeah.
And
for whatever reason inspires them.
The problem is what I found over time is later, when they get really involved, partly because of machinations of the party system, they can't get away from the fact that they only look at it from a party political lens when you deal with them.
Yes, I have had some exposure.
It drives me spare.
Yeah,
so they might have started off saying, I'm trying to do this because I care about the world and I have these beliefs and I want to help people and I want to actually change the world. But somewhere along the world it becomes, Dr. Moy said something that was slightly critical of us, so therefore he must be a Liberal Labor Party stooge. Or Dr. Moy said this, or he's our friend, he's our friend, he's a Liberal, like they can't...
You're a friend of whatever.
Yeah, 1 minute they are, 1 minute they are, 1 minute.
You're a friend
I've got to say, I found this after a while that really drove me spare after a while, that what we were trying to do was actually talk what was right. We go out there and say, look, this is not right what's happening here, or this is right what's happening here. And the parties would straight away box you into you were against them or for them, because you actually said something that either supported or went against their view. And I found that's when I think you actually need to probably actually have a good cold hard look at yourself as to why you're still there, because I think as politicians they've actually lost what it is to be why they started. They've forgotten what it is to be started. And having been in the role I had, it was quite interesting actually to have been boxed in. 1 minute their friend, 1 minute their enemy, and
I can't cope with that sort of thing. I don't understand. I have to ask people, like, are you messing with me, or did you mean that? Or and then it's like, we don't have people being that direct.
You do need to understand. I mean, my role, you just need to understand what you're dealing with, and part of the reason why I'm not going to, I wouldn't ever become a politician or continue, and I need a rest from all this, is because it makes you quite. You can really, you're in a very strange world. I was talking to my wife just this morning. Actually, I was talking to her about this morning. She said, and she was saying, you know, like a few of my friends have been saying, oh, Chris, you've stopped. You must be really feeling lonely and empty. And no, I said, no, I don't have to read the paper and do the calculations of what line of attack we need to get what's right done.
Yes.
So I you know, like what would happen every day, I would read the paper.
You can't just go in and go, that?
So basically I would be working out, okay, and I was talking to my wife about exactly so she started, I think she started to understand, like every day I would read the paper or I'd read the ABC News or whatever. Yes. Or listen to the TV. You make
sure you've got them all. You've got to have SBS, you've got to have Guardian.
What I'd be doing, I'd be looking at what we'd written because we'd get our media feed. Yeah. But what I'd be going is, okay, this is our line of attack. No, this is not a good week to go because Ukraine's on the front page. We won't have any line of attack to get what we need done. We need to hold the line of attack till next week. How do we do it? Do we do it through a press release? Do we do it? Is it through a is that what we need? You know, is that, or do we need to say something in the media, or do we have to do something on Twitter to get the ball rolling? It's kind of interesting that I don't have to do that anymore, and I realised how it is quite it's quite an intense strategic game that gets played out there, which is why I think the politicians after a while start to forget what it's all about. They actually start to forget. That's why they
say they're like diapers. They have to be changed often and for the same reason.
Not a bad idea.
Yeah. So one of the things with this healthcare crisis, so we had ambulances ramping, and they're getting more, so there are more ambulances ramping now. But why do we have a healthcare crisis, and why are doctors wearing these shirts? And you've got people with words like moral injury, breakdown, and people being burnt out. I mean, how do the general public support people and their hospitals at this time, especially with COVID? And why do we have this healthcare crisis? I mean, is there a fix?
We've been pretty dumb in the way we've actually dealt with it. Yeah, Australia's been pretty dumb. Look, I'll talk about two areas which are probably the ones I'm closest to, obviously, but there's several. I mean, one is prevention. I mean, prevention. What about things like a sugar tax and things like that? Just can't get over. Prevention of things like which to try and reduce the burden of disease. The next thing is general practice, properly funding it, because if you had a properly functioning general practice, it wouldn't just be this conveyor belt.
They want you to do everything.
It wouldn't be a conveyor belt. What we'd do is change the way general practice works, so we could actually look after people without this, this conveyor belt idea
more
about
of a
funding.
Community focus,
and we could actually focus on bring you in when we need to, use remote technology, look after you, call you when we need to, provide care in a much more flexible form, be able to develop a long-term relationship with your GP, because then you won't have this feeling like you're a number. Then within hospitals, properly funding them over time. I mean, clearly we don't have enough beds and we don't have doctors and nurses, but that lack of workforce planning for that and actually needs fund planning has actually been very poor. But all along, prevention, making sure we have a strong general practice so that people are less likely to end up in hospital in the next case, and making sure we have enough beds. They're pretty damn obvious what's happened, and Australia just has not kept up with what it's really needed.
I agree entirely with what you're saying. I'd certainly like to see my GP practice. I mean, I go up to Norton Summit, and I'm decided I'm going to keep going there because they know me and I feel safe there. And I feel safe to be able to have conversations that are you can't just meet someone and generally start to have as big a mouth as I have. That's a lovely thing to have. But I'd had the same doctor for years and years, and the same doctor that my mother went to, and then you get all this genetic stuff, and it's like, oh, that's interesting.
And some of that stuff is of. It's not just about knowing all your medical conditions and your allergies and medications. It's actually understanding the background. And that makes a huge difference. It adds a great value, understanding the background of somebody and what they're like and what their supports are like to be able to help people. I think that's...
So we've forgotten, we think community care is aged care or disability care, and we've forgotten about primary care.
And they need to work together a lot more. I mean, I'd love to work in a world where we did work a lot better together.
We had a healthcare system and not a hospital system.
Yeah. Well,
I think it will become more like that.
I think it'll be forced to, because I think the burden...
Communication just has to happen.
I think the burden of aged care and also chronic disease, which includes, for some significant portion of that, some of that is disability as well, just means that we have to change the way we provide care, because currently the way it's being provided is really in a way which doesn't... It's a conveyor belt which isn't funded properly, but also isn't suiting the needs of the very people.
Henry Ford had a lot to do with the original design.
Sorry?
Henry Ford had a lot to do with the original hospital. And it was that mass thing. But, in the last 100 years when our hospitals healthcare has changed, and there's all these different, healthcare is more a part of integrated in day-to-day life, like you're talking about lifestyle and diet and wellness and the wellness revolution, which is,
let's talk about a different world, okay? So at the moment, the problem is that to see a general practitioner, how they're funded is you're funded when you actually see the general practitioner, either by turning up at the practice for your 15 minutes, or by having made an appointment to have a telehealth consult, okay? Now, the problem is at the moment is that's the way it's funded. But really, for most people, what they don't actually often need to see the general practitioner, because sometimes they're just seeing it to get a script.
Yes.
They're seeing them for because you have to fill out a form and that sort of stuff. And the reason why you have to do that is because the only way to do it is you have direct contact with the GP. If we had a much more holistic funding where the contact was separated, and what happened then is the practice was funded to provide, say, a multidisciplinary team. Would be a nurse working with a GP, working with a pharmacist, making with a social worker, all those things, OT, whatever.
Allied health.
What would happen if we were funded to do that? What could happen is the team, and there was a disconnect between you. The only way that the practice is funded is for you to see the GP. If we could get a disconnection from that, and we end up in a world we could work as a team, what could happen is that the nurse would be maybe the one who monitors you. Okay, checks in on you every week and say, how you going? Do you need this? And then what would happen is that the GP could just write the scripts when you get a list, you write these things. There's no requirement to see them. That's
awful when you need to, for me, I have heart medication.
But then,
if my chemist loses my script and I think I've got one, or, something just happens and I feel terrible ringing up. Can you,
But then what happens then is that when you really do need to be seen, then you see the doctor. So the team is looking after you, and you only have to see the GP when it's required, but you do have this long-term relationship with the practice that looks after you. And I think...
From a liability point of view, there's less risk for you as well because you've got a relationship with all those people.
And also, I think what it does is it actually suits the needs of people because they don't have to come in just to see the doctor for your script at the moment. So there will be a greater disconnection. And I think, look, we're heading that way, but the funding model has to get away from this fee-for-service, bang, 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 bang. What it has to be is a lot more about making sure that practices get what we call a block fund to look after you, so that it's less about the unit cost of getting that.
Well, that wouldn't mean it'd be like an NDIS thing where we'd have to sort of... give a DNA imprint to know
that's the hard thing. And that's the discussion that's been happening. That's this strengthening of Medicare discussion. And the most of this is around a thing called voluntary patient enrolment, which is to formalise your relationship with your GP, which you have at the moment, but it's not formal.
No.
What you would do is you say, that is my GP, that is my practice.
He always looks horrified when I turn up. So, oh my God, she's back.
But you be enrolled. What you would do is you voluntarily enroll with that practice. You're saying, you're making a pledge that that's my practice. What could happen then is the extra funding comes to that practice, say if you're an individual with higher needs, so that therefore that practice could
He can apply for that and say, well, I need to go to the next level. Yeah, that would make sense.
That is a different way of funding. Instead of just this, you have to see the doctor.
You could get rid of my aged care as well, and then they could manage that as well.
Yeah, but that's a different world, and I think that's the way we've got to head, away from this conveyor belt type medicine, which I think we're in at the moment, unfortunately.
Well, pie in the sky, the last 4 industrial revolutions, and sort of lifted up with Maslow's hierarchy of needs, and the 5th one, we're sort of at self-actualization, and they're saying, artificial intelligence, like artwork, and you're talking about artificial intelligence, green technology, people, things being less manually intensive. So you're talking about people wanting to work for purpose, a more inclusive society, and where things are more about wellness. Now, wellness is a word that, you know, if you start listening for it, it is being bandied around an awful lot. And I think people are definitely sort of more wanting more bang for their buck in life. And it's just empowering people to be able to do that. And that's not just people with a disability. I think there are a lot of people, it's not whether you voted Liberal, Labor, Green, or, you know, orange or yellow. It's did you vote at all? And were you serious about your vote? So
we're back into politics again.
No, but it's in everyday life. As far as a community, there are ways that you can actually support your GP and your hospital.
We need to be allies a lot more. And look,
that was what once I understood. I always felt terrible if I saw the nurses having to attend to my clients. Like, oh my God, I should be doing that. You need to be doing the nursey bit. And once they gain some trust in you, they'd like, oh, thank goodness, you know, you do all, I'll do it, you know, and if I need you. But that was that trust, because there wasn't, for them, they were taking a risk in me. And because support work is so variable, we have people that, you know, don't even have a first aid certificate, they don't have manual handling, and they could very well be a liability. If we could, you know, sort of regulate that a little bit, then maybe that would also help as well, because I do get their point with some of what they have to deal with. You know, they're almost thrown out the car as they go past by the support worker. It's like, I'm going on holiday. There is an element of that. And there are also, you know, some very, very good people out there, but it is variable, and we just need to make it, you know, every time I go to a GP, I get a GP. You know, so if I get a support worker, they all need to be support workers. You don't go to a doctor and they're not really a doctor. Well, not in this country. Yeah. So what was the best thing you feel you accomplished whilst at the AMA?
Good question.
Apart from a good knowledge of politics.
Look, I'm actually a bit overwhelmed about how much we got to do.
Yeah.
I mean, look, I've got a bit lucky. I've got to do a lot of things over my time, and you know, it's been things like, I mean, I still get back to my two initial focuses were trying to get the advanced care directives and 7-step pathway through, and also the My Health Record. And my view is probably interesting. The big silver lining that came out of COVID has been actually digital health, because I think suddenly people who'd been naysayers for a long time suddenly realised how this could be the empowerment for a lot of people. So things like electronic prescribing would not have happened had we not kept...
I know.
And so I was
that is so useful.
So I was part of a team trying to sort of get that going, but that sort of thing helped. The use of My Health Record to be able to look at the Australian Immunisation Register, and you look at immunisation status.
Well, telehealth is amazing for people with disabilities. Yeah. I was able to look after a chap in Tasmania who was having a hypertensive episode, who was 1.2 kilometres from his driveway, refusing to allow me to call an ambulance, which, you know, he was going to get one called anyway. But, you know, he was able to get with a GP in front of him, and we were able to go through some steps to, you know, sort him out, which... I was like, well, thank you, because that's something that anywhere we could manifest this person who was, you know, had the expertise to be able to ask a couple of questions, and with me sort of filling in a few gaps, we were, you know, saved a trip into hospital.
Probably, I mean, if you want to just take this as a bit of advice, the one thing I've learned, because I took a lot of shit over My Health Record to try and support it going through there, because I could see what it was about in the end. The reason why I wanted it was because what I was seeing, the thing that has always driven me was the fact that I have patients in aged care facilities who turn up to a hospital with no information about their medical condition, their allergies, and their medications, but also don't have an advanced care directive, and so doctor has no idea what to do. So if you're wondering why your doctor makes the wrong decision...
Sometimes they rattle with about 15 different meds and you've got no idea.
If you're wondering why your doctor sometimes makes a decision, the doctor in the emergency makes a decision that you wouldn't have made, it's because they can't read minds. But the thing is they don't have any of that information. So my health record was all about, first up, having the advanced care directive, which is the person, representing the person and the wishes, but also having their medical history available at the point of care in the emergency department. Now the thing was that for me, I've always kept that, and I've focused, that's my whole thing was always about doing that, and we're so much closer to where we were for that. But the thing is that all these offshoots came off, like electronic prescribing and these other things that have been really important. And what I'd say is that I took a lot of shit over this as we were developing a lot of it, because most meetings, when you go into a meeting, and I think you'll understand.
People going Big Brother.
No, most meetings are going there and they're finding reasons not to do anything, because quite often there's conservatism, they can't too lazy to do anything. They're finding all the problems. Look, in a room, when you're in a meeting with a room, I can tell you now, right? Most people are going to be negative. Very few people are builders. The second thing I learned is that, and this, I can say this now, is, and this has been proven with my health record and electronic prescribing, there's a risk of doing something, which is a lot of the naysayers are going, oh, sure, there's a risk of doing this, or privacy, blah, 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 blah. COVID proves something. There's a risk of not doing something.
Yes.
And sometimes it takes people who are builders and brave to actually be able to push things through against the tide. And so that's probably a message for yourself and a lot of the viewers.
Absolutely.
You actually, the two things I've learned over time is it's easier to be a criticizer than a builder. And because these criticizers will, because it's a lot easier to sit there and just find all the problems and things.
Yeah.
Very few are real strong builders. And then there's a risk of doing something, which is the naysayers are going, oh yes, if you do this, there's a risk. There's a risk of not doing something. And so my health record was an excellent example. Everybody's saying, oh, but this could happen. Guess what? My health record proved that there's a risk of not doing it. And now we've found that, we sometimes have to have people that are brave to be able to push things through against the tide.
I think with risk management, people have considered force majeure, fire, flood, terrorism, and all those sorts of things. But I think medical emergency was something that certainly in Western countries we didn't think. So I think we now know, and we can take that risk management and now apply it to other areas like ageing and chronic illness and disease, and take that risk and go, well, if you really want to save money, and then come back to that community practice thing, which I think that idea is just...
Yeah, I hope COVID is actually, even though it's been a very stressful time,
I think it's the protagonist that has really been a builder.
It's the lighter that lights the fire under the fact that we have to change in so many areas. And we have to have guts, and that's health, disability, aged care. And we have to have that attitude that, right, okay, there's a lot of people out there who are saying reasons not to change, but sometimes you have to look at why. Often it's vested interests and it's conservatism and can't be stuffed. But you've actually got to also listen to people that are brave enough to actually propose solutions, because they're actually the ones you need to listen to.
And with travelling with my children, I certainly line them up for every jab that they required when they were talking about yellow fever and really fun stuff. We were there.
Excellent.
Yeah. So thank you for your time, Chris.
Pleasure.
It's been an honour, and I hope that for a lot of people listening that they take that into heart and try and build relationships with their primary care and understand how funding
works. Doctors are human, and they want to show their humanity. Get to know them, and most people are going to be really fantastic with you. You just need to give them enough time.
Yeah. Well, thank you very much.
Pleasure.